Thank you. I'd like to thank the organizers for inviting Nova Scotia to tell their story. There are many stories across Canada, so we feel honored to share with you ours. So I think we'll start with this. This is a quote or an excerpt from a piece put in the Huffington Post by Alan Castles back in June of 2011. And he says, a year ago, Nova Scotia decided it was going to try and put a stop to the waste and harm caused by the overuse of diabetes test strips and cap the number of strips it would cover for non-insulin dependent diabetics. This sounded like a reasonable thing to do, and I admired their pluck. So this is our story. I'm going to take you back to before that excerpt was in the paper, and then I'm going to take you up to where we are today. So just like every story, a story has a beginning and an ending. Some stories have a different ending and a plot that twists and turns, and some stories don't quite end. So I'm going to share with you one that's had a plot that twists and turns. It's still ongoing. We don't quite have an end, but it's an interesting story. So just to set the story or the stage, you always need to have the context. Our story is going to be about reframing or challenging, for want of a better word, one aspect of historical diabetes practice, and that's self-monitoring of blood glucose. To some of you, it might be known as capillary testing or home testing, and learn more about how to deal with perceptions and practices that are not grounded in evidence, but merely long-held beliefs. So to talk about why this is important, I think we need to understand diabetes in Canada, and I'm sure I'm speaking to the converted here. So very quickly, diabetes is a significant and growing concern. 10 to 12% of our adult population have diabetes, and that figure is much higher in those over the age of 75, and even reaches as high as 25 to 30%. We have an undiagnosed population now classified as pre-diabetics, and those numbers reach 20 to 25% between the ages of 45 and 75. Both these numbers are growing. We've seen a 20% increase in the prevalence of diabetes over the last 5 years, and I don't expect it will stop. We know that the approaches to management vary by diabetes type and treatment. So if you have type 1 diabetes, often diagnosed before the age of 18, usually as a youth, the only way you manage your diabetes is through insulin injections, or if fortunate, through an insulin pump. The other type of diabetes, which makes up 95% of the diabetes cases in Canada and probably across the world, is type 2 diabetes. And it can be managed by lifestyle early in the development of the disease, maybe managed by lifestyle right through the course of the disease, but in others it's progressive and it may add oral agents or it may add insulin. So we know that depending on diabetes type, the treatments will vary. We do know that some approaches are more efficacious than others. So if you look at insulin and oral agents, or the use of even nutrition or weight loss, all of those are efficacious in reducing A1C, which is the marker which can reduce short and long-term outcomes or health outcomes of diabetes. But we also know that some of those efficacious treatments in the type 1 population have found their way into the treatment of type 2 diabetes without the evidence that we know is needed to support them. And an example of that would be monitoring of blood sugars. So there's good evidence that shows that if people with diabetes taking insulin monitor their blood sugars and use those results to change their treatment, they will make a difference in their own health outcome. What we've seen is that creep into type 2 diabetes, where not all people, or not people with diabetes managed on lifestyle only, can really make that impact, and really we're not seeing the same change. So we also understand that the management demands placed on people with diabetes are significant and overwhelming. You would all know people who have diabetes, they have to change their diet, they have to increase their physical activity, they have to manage their stress, they have to plan for sick days, they have to plan for when they travel, when they're driving the car. They have to manage other comorbidities, which are often packaged as hypertension, dyslipidemia, and other conditions. So it's overwhelming, and we give them a number of tasks to change. So what would you think if we had patients focus on a treatment that really had no evidence, but allowed them to feel that they were making significant improvement in their care? And one of those would be monitoring their blood sugars. So if patients have limited wherewithal or really have a number of competing demands and pick one behavior to change, if they pick monitoring, faithfully monitor their blood sugars, record it in a book, taking it to a provider, and nobody does anything with those results. They now are not focusing on things such as what they could do with nutrition, weight loss, or physical activity. So I think it's important that we understand that we need to help our patients, and patients need to help us guide what's the best management for them. We should focus on patient self-care and those aspects of care that have proven efficacy. So this is not the only story happening across Canada. CADTH has done phenomenal work and is supporting all provinces and territories with a number of initiatives, and I won't go into them, but you could go to every province and territory and find out that there's been significant work. So this is where the story begins. This is a CADTH report that was actually put out now 3.5 years ago. So in June or July of 2009, they put out a number of key messages. We're going to focus on the message in the yellow, which says routine self-monitoring of blood glucose is not required in the type 2 population. Now you might think that that's a great thing. People who are burdened by diabetes and wouldn't necessarily need to test their blood sugar might willingly give up those strips, but that's not the case. That's not what we found when we started to roll this out across the province. It's not what CADTH has found as it's come up against some bigger roadblocks. So there are a number of cost considerations, and we're not all driven by cost, but needs to be considered to the individual in the system. We know that one test strip costs anywhere between 70 cents and $1 per strip per individual. You can look at the Canadian figures and you can look at our Nova Scotia figures and realize that when we looked at our data in 2008, $8.5 million was being spent on medications, but an equal amount on test strips. Now, we're a population of less than 1 million. This is reflective of only our pharmacare program, seniors over the age of 65, a small segment relatively, and over 4 million of those were on people that were using just drugs or no drugs at all. We also, at the same time that we embarked on this in Nova Scotia, were fortunate to have a study taking place through family medicine at Dalhousie University, and it was a qualitative study that allowed us to talk to physicians, pharmacists, and diabetes educators to see what they were recommending around self-monitoring of blood glucose in a well-controlled type 2 population. And I was blown away when I was part of that study group to see and actually read the transcripts that said, we have huge variability between our provider groups, as you might expect, physicians telling different things to patients than pharmacists and diabetes educators. But even within our provider groups, huge variability. So if we look at patient-centeredness, what we're doing is sending very many mixed messages to our patient population and really harming them as they're trying to make their way through this myriad of treatment changes. So the summary messages for us are very clear. CADTH showed us through a very rigorous process that there's really not good evidence in support of testing for those who have type 2 diabetes not on insulin. There's no clinically relevant improvement in their blood glucose control or patient well-being, and there were also some studies that actually showed harm in a population that may be monitoring their blood sugars and becoming over-anxious with the results and not being able to do anything with those results. We know that monitoring should be linked to specific patient actions. We have substantial spending. We've got inconsistency between our healthcare providers, putting the patient squarely in the middle of that. So in Nova Scotia, we need to focus on a collaborative approach. So this is very busy, and not to go through it in detail, but CADTH released their report in June of 2009. They followed that with cafe scientific sessions, which were very well done across Canada, aimed at the public and providers. And you'll notice in the orange block at the bottom, Nova Scotia put their policy out in February of 2010, restricting strips to 100 per year for this specific population, not eliminating them, but restricting it. And within 4 to 5 days of that policy being released, it was rescinded. It was brought back in because there was a huge public outcry by people with diabetes who weren't informed and by an association supporting people with diabetes. So I think we stepped out too early with our policy. You'll see all the work on the right actually shows we had just started to get some consensus development going. We were developing a decision tool because as providers, you can't stop a practice that's been 30 years in the making without giving them some logic. So our decision tool helps the provider work through who should test, How often should they test? For how long? We then rolled that out through workshops, through academic detailing to both physicians and pharmacists, and we've wound it up with doing interprofessional workshops across the province that ended in December of 2012. We've reached a lot of providers. We've seen a huge change in attitude and approach. This is a tool, I won't go into it, but if any of you want to find it, it's on the website for the Diabetes Care Program, and it is supported by videos where we actually have clinical specialists and patients telling their story about what it means to them. So what we've learned, well, I think we stepped out with our policy too soon. I think really what you need to do is lay the groundwork with informed educators, informed and clinical champions. So this is a multi-pronged approach. It continues over time. We're going on to 4 years since the release, or close to 4 years since the release of the CADIF report, and we need to continue this work. So it doesn't stop. There's much that has to happen. We do know that providers are making changes. We're seeing that. Patients aren't being entered into diabetes care programs or centers anymore with meters. We have letters that are that are supporting reduced testing, and patients are welcoming the change. They welcome the fact that they don't have to test their blood sugars as much, and if they are choosing to test, they can now choose far less testing. So in closing, I think this quote by Heather Dean is important. Are we guilty of treatment creep? And I think I mentioned that earlier. What we saw is the treatment of type 1 diabetes filtering into a type 2 population without the evidence to support that. We need to convince leaders like you in the room that in the healthcare settings, we need to abandon this practice and think more appropriately about it, and that we need to redirect the savings from things like unnecessary use of strips to other things that really do make a difference for people with chronic disease. So these are the acknowledgements and a special thanks. Very big partnership and collaborators in our work through Dalhousie University, the Drug Evaluation Unit, the Department of Health and Wellness, CADIF, and then the Nova Scotia PATH program that you've heard about as well. So thank you.